Hi everyone, and welcome to week 5 of the rolling teaching programme for sickle cell disease. And for those of you just joining in the programme, my name is Christopher Dean. I'm the paediatric red cell nurse specialist here at ECLH, and I'm also the lead nurse for education and training for our red cell network. So this week we'll be covering the topic of the initial presentation to the emergency department for our service users, with a focus on assessment, investigations, and analgesia. Before we begin, I'd like to go over some learning objectives for this week. And these include, we'd like the candidate to gain more of an understanding of the process our service users go through in A&E prior to admission plus or minus discharge. Candidates will understand the importance of pain control and the patient key record if there is one available. And candidates will be aware of the warning signs which need urgent escalation and review. Then finally, candidates will be referred to the local antimicrobial guideline designed especially for our patients.
So starting off, the introduction to decision to admit. Okay, so our most common presentation for people with sickle cell disease coming into hospital is due to vaso-occlusive crises. So I'll very briefly talk about what that actually means. So in this picture, as you can see, the normal red blood cells are able to flow freely through the blood vessels and able to pass on oxygen and oxygenate the body effectively. However, when the red blood cells with sickle hemoglobin in it deoxygenate, they polymerize, causing these long, sharp rods to form, making like a little crescent shape, as you can see in that picture. It's called a sickle cell purely because of the old farming tools that they used to use to cut down wheat, so like a scythe. So it's like a C shape or a crescent moon shape. These are quite inflexible. They're pretty poor at transporting oxygen, and due to irritation of the blood vessel walls, lectins are released, which causes stickiness to happen, causes clumping to happen, all the other cells joining the party, and eventually cause a blockage, which by its nature blocks blood flow through the vessels and also inhibits oxygen transportation around the body, so causes ischemic injury and pain. The most common reasons why this happens and why we might be able to explain why it's happened is due to infection. As we all know, when you have an infection, it causes an inflammatory cascade to happen, which will cause the crises to occur. Cold exposure as well, because as we know, cold weather causes vasoconstrictions for our veins. So for those of us who do phlebotomy or cannulas, we know that we like a nice warm hand or warm area to be able to increase the chance to get access. And dehydration as well, because when you become dehydrated, your blood becomes more viscous and sticky. And if it's moving more slowly and the blood is more sticky, it can cause blockages to happen quicker and easier. So that's just a very, very brief overview of what a vaso-occlusive crisis is. And like I said, it's the most common presentation to ED with the pain. So let's look at the journey through A&E. So the patients come into A&E, they check in, and as I'm sure we're all aware, when you go into A&E, the first thing you do is you meet a nurse, who'll triage the patient to assess what the severity is and how quickly they should be seen and assessed. So triage is the assignment of degrees of urgency to describe the order of treatment. So the most commonly used triage system in the UK, and in fact, pretty much universally across the world now, is the Manchester triage system. So as you can see on the right-hand side, it's like a little algorithm or a flowchart, and the colours that correspond to it is the category it falls in for how quickly they should be assessed and seen. So at the top is orange. So if you get categorized as an orange, then you are the highest priority. Then moving on to yellow and then on to green. So this one I've copied from the Manchester Triage book and from the course materials is relating to pain. I couldn't find one specifically relating to sickle cell as a condition, so I use pain as its most common presentation. So if you have severe pain, you automatically go into the orange category. And moderate yellow and mild pain is green. So the Manchester Triage system is a clinical risk management tool used by clinicians worldwide to enable them to safely manage patient flow when clinical need far exceeds capacity. So it's just used as a standard usually in ED. This was developed back in 1994 the different clinicians all got together and developed this massive system. Usually triage nurses tend to be band 6s or very experienced band 5s who have undertaken training, so that are able to triage effectively and not cause any sort of prevent any serious injuries happening or serious incidents. As I said, it's the international gold standard for triage. Most places use it, and it tends to work quite well. Because what sort of questions might the nurse ask at triage? Does anyone want to suggest anything? Like the silence, I'll just keep talking.
Sorry, is that questions asked of the nurse to the patient or the patient to the nurse?
Nurse to the patient.
Nurse to the patient.
They say they've just checked in and the nurse is going to do the triage and assess how quickly they should be seen.
Gosh, that's really interesting. I've got no idea. I should know, shouldn't I? So they must do a pain score. I don't know if they do that first or not. Do they ask a generic question? What's your immediate problem? Something like that.
So yeah, what they... Oh, sorry, Jane, I'm just going to mute you because I think you're chatting in the background. So generally speaking, when they check in at the reception desk, when admin are booking them in, as it were, they'll put down what we call a presenting complaint. And sometimes that's quite specific. Sometimes it's quite irrelevant. It might come up saying pain, but we don't know what that means. Have they got sickle? We just don't know. So they'll clarify what the presenting complaint is. So they might come in, it might just say sickle cell on the presenting complaint originally, then they see the triage nurse and they have no idea apart from it just says sickle cell. I see James put in the chat, what do some vital signs and a brief history of the problem? Yeah, one of the main things. So history, when did it begin? Where is the pain? They want to try to specify, is it chest pain? Do they need to think, is this a heart attack? Is this an acute chest syndrome? But we have to be mindful that triage nurse isn't necessarily hematology trained at all. They might not know enough about it. And we know different specialties need a lot more education than others regarding sickle cell. So they might not know what the warning signs are. Then we like to know what the medications are in the last 6 hours are. So we need to think about what have they had at home? Are they on any regular medications at home? Are they on home opioids, for example? What might have LAS given them? So LAS might have given them some subcuts, they might have given IV opiates, they might have given some Entonox. So we need to be mindful when we're prescribing the initial doses, what they've already had, so we don't overdose them and cause a respiratory suppression. Allergies as well, it's one of the common questions that is asked, whether or not we might give them something that they might react to. Past medical histories, so this is where we're going to confirm that they have sickle cell disease and whether they've got anything else like hypertension, whether they have elements of chronic pain, whether they have avascular necrosis or any other pre-existing condition that we need to be mindful of. Even though we know it might not be the presenting problem, we need to think of how it could interact. What regular medications they're on, so we'd like to know what they have so that we can ensure that they're prescribed appropriately, what sort of disease modifying therapy they're on. So for our patients with sickle cell disease, if they're on disease modifying therapy such as hydroxycarbamide, it's good to know that, and they like to know the doses and how regularly they have it, because again, they're not necessarily going to be experts and know what frequency and what the doses are. Pen-V and folic acid, as we know, our patients tend to take, should be taking prophylactic antibiotics, and if they're not allergic to Pen-V, what the alternative is. Folic acid as well, just so that we know that they're taking it and they can be prescribed and won't be missed. Travel history as well, so if we know our patient might have, say they've been on holiday, they've gone to a tropical country, we need to make sure there's potentially not an infectious diseases cause and they could be isolated appropriately if needed post-triage. They also like to know about social history. Like, who do they live with? Do they have a package of care? Should they have a carer with them? If they're to be discharged from ED, are they going to be safe to be going home by themselves? Should someone be picking them up? So in terms of vital signs, yep, they'll do a full set of vital signs. Oh, Karen, you have your hand raised.
Yeah, sorry, going back to the previous slide.
Yeah.
Obviously, you know what I'm going to say now, but you don't ask them about their transfusion history. So you get all medications, but not transfusion.
Yeah, so it's not necessarily. I think it would be the first thing that triage nurses ask in terms of what sort of prophylactic treatment they're on. I mean, fortunately, with systems like Epic or Cerner, it's quite easy to find that, and we educate our patients to be able to be forthcoming with that as well.
Yes, I think that for me that's the learning, because I think a lot of patients wouldn't necessarily disclose that they're on a regular exchange program, or that they've had, more importantly, that they've had hyperhemolysis or delayed hemolytic transfusion reactions in the past. If a nurse says to them, what is your past medical history, or what is your regular medications? Whereas if it was framed around transfusion, they'd probably go, oh, and by the way, did you want to know I've got an antibody, or
yeah, I mean,
I'm on regular transfusion?
I mean, that would be ideal.
Yeah, but that's a lot to ask of a A&E nurse without experience. I understand that. I just wanted to mention it.
But I mean, that's why I think we should be bringing back those little cards that we gave out to patients with the antibodies and everything like that. Because if they come in, say they're having aplastic crises, the first thing we're going to do is want to give them blood, right? So if we're going to give them something, they're just going to hemolyze anyway. We're not helping ourselves. But yeah, that's one of the main reasons why I think we should get those cards back. And I know the Whittington are developing some. I believe, Olivia, I don't know if you want to comment on that. Is that true?
Yeah, we had developed a system where the triage nurses some of them actually do give their first dose in triage. So as soon as the patient is says I'm sickle cell disease, they straight away get their protocol already at triage and give their first dose analgesia. So we do have a system like that where we do have a card. So that card, they also have a card in A&E that is probably red. So that will be in their little pass or whatever thing that they call it. So that lets them know, okay, this person's got sickle cell disease, and then things flow from there. So that's what we've actually started.
And does your card have transfusion details on it? Does it have a blood group, antibodies?
No, we tend to give the patients who have had hyperhemolysis, we tend to give them a card separately to keep for that. But that mostly gets disclosed, I think, when they actually reach ED. And then they have their first encounter with the doctor. That always gets disclosed there, that if they've had hyperhemolysis, or we make sure we keep it on their patient key record.
Okay, thank you.
You're welcome.
So vital signs, just briefly, we all know what vital signs are. We're going to check the pain score. We're going to do the heart rate, respiratory rate, blood pressure, oxygen saturations, again on air, because we have to be mindful of acute chest syndrome that our patients might present in. Generally speaking, the oxygen saturations are usually kept on the patient key record, what their baseline is, because the patients might not know what we mean, what percentage they're usually on. So that information should be available. Temperature as well, because we know our patients generally asplenic. They're on the prophylactic antibiotics. We might need to initiate antibiotics quite quickly, according to the microbial guidelines. Trying to get my words out, sorry. Glasgow coma score, and we should also be doing an AFPU as well, just in case. If they've been given something in the ambulance and that's above what they're used to, they might be oversedated. So all the above vital signs should be done 30 minutes until pain relieved, and then 4 hourly. If on strong opioids, observations should be 1 hourly for the next 6 hours at least. So they've come through triage, they've been sat back in a waiting room if it's appropriate, or moved to resus or whatever. So in comes the clinician, so it could be an SHO, it could be a registrar, it could be the consultant, depending on who's around and what the triage is like. They need to understand what kind of sickle cell disease that our patients have. As we know, there are different types, but it's always handy for them to know what type they have and sort of phenotypic nature they have. What is their current treatment regimen? Disease-modifying therapy. So at this point, usually is when they ask whether they're on hydroxycarbamide, whether they're on top-up transfusions, red cell exchanges, and when was the last time they were exchanged? Are they due one? Have they missed one? Could that be explained in this kind of presentation? Have they had any previous complications? Have they ever ended up in ITU? Have they ever been ventilated? And how many VOCs have they had in the last year? So that we're aware of their kind of history and trajectory. A nice little picture of doctors there for you. So immediate action that needs to be done. We need to have a look at their patient key record, and that should be available within easy reach, whether it's online, whether it's in like a hospital passport type system, whether it's on Cerner, Epic, or whatever systems that we will use. So my work phone's just going off. I'll hold off on that for a moment. And we need to prescribe and administer analgesia within 30 minutes of arrival in ED. As we all know, that's a national target, but doesn't necessarily mean that. And if they haven't got a PKR, then we need to follow the local guidelines on a needle. I'm not sure if you guys have those, or they're called those in your hospital, but the needle is like our little quick algorithm for how to manage these patients. Just quickly introduce the WHO analgesic ladder. So if they're on mild pain, they can just have paracetamol or NSAIDs. If it's mild to moderate, they can add a weak opioid, so codeine, dihydrocodeine, tramadol. Or if it's severe pain, then we need to give strong opioids, so morphine, fentanyl, methadone, and oxycodone. I'm really sorry, guys. Someone's really wanting to get hold of me on my work phone, so let me just take this call for 1 second.
Olivia, would it be possible for you to send me an example of the card that you use in A&E?
Yes, I could do that. Who's speaking, please?
Sorry, it's Karen Madgwick.
All right. Okay.
Have you got it? I'll put my email address in the chat. Is
About
that all
to
right?
say that. That's fine. Thank you.
Thank you.
Okay, sorry about that, guys. I am back. It's always the way that you get a call. So yeah, so step 3 is severe pain. So morphine, fentanyl, methadone we don't really use in sickle cell disease anymore. We used to, but not anymore. Or we can use oxycodone. We did have diamorphine on our protocols, but unfortunately we've had to stop that now because when it's gone, it's gone. And most hospitals have run out now. I think we have some lying about here, but I think other hospitals are completely out of it. I think the Whittington's completely out. And it's just how it's going to be now. So we've had to transition some patients over from diamorphine onto other things like morphine. So the needle, I just wanted to quickly share what the analgesia part of our needle says, so our little quick algorithm. So we follow the patient protocol. If not available, follow the below. So for mild, moderate, paracetamols, NSAIDs, dihydrocodeine or codeine oromorph. But if it's severe, strong opioids are needed. So most likely need subcut morphine, which is dosed at 0.15 milligrams per kilogram hourly, or subcut oxycodone 5 to 10 milligram hourly. However, generally speaking, it's hourly or 90-minutely to hourly that the parentals are needed. And after which, within 24 to 48 hours, we try to switch our patients back over to orals on the equivalent dose. But if they're on the opioids, we need to prescribe the adjunctive treatment, so antiemetics, cyclizine, orally or subcut. We don't do IV. Antipruritics, so chlorphenamine is the standard, give that 4 milligrams orally QDS if needed, and start laxatives earlier rather than later, because we don't want to constipate the patients further, because we know when sickling is happening, that causes constipation. The opioids cause constipation, and the constipation in itself can trigger another crisis once you've got over this one. So it could be a little bit complicated and long lasting. So just want to give you an example of what a patient key record looks like for us at UCLH. So baseline oxygen saturations for this patient was recorded in February 2018, and we know it was 97%. When we start to worry is if their oxygen saturations drop more than 4 or more % below what the baseline is, and that's when we need to do an early consideration for acute chest syndrome and activate and escalate treatment for that. So we separate ours into acute settings. So this is what this patient can receive in A&E or in the daycare unit, because sometimes we're able to get our patients into daycare first and then get admitted from there. So this patient has 5 milligrams subcut morphine 2 hourly, and we can review that after 30 minutes of the dose and up titrate if required. If pain does not appear to be too severe, then give oral medication as below instead. So for inpatients on in for a max 24 hours, they can have parentals, so subcut. And then we need to dip down to orals. Subcut morphine 5 milligram 2 hourly, or aim to convert to Severodol 10 to 20 milligrams 4 hourly PRN. Severodol is just a brand name for immediate release morphine, so your trust might be using something different. Please prescribe regular background analgesia. Most recently, morphine sulfate modified release 30 milligrams was used. That was in June. And then for outpatients, we need to liaise with the GPs before discharge for follow-up prescriptions. So say our patients being discharged with a few days worth of opiates for when they get home. Some of our patients are on home opioids anyway, so we liaise with the GP to say, this is what we're doing, this is our weaning plan, are you happy to continue? And because of this, our discharge summaries need to be finished and written as quickly as possible so the GP can have record of that. So for this patient, they can have paracetamol, ibuprofen, tramadol only to be discharged with 72 hours worth of medication. Of note on that patient key record as well, we would have their transfusion plan as well. But I couldn't fit all that information on the slide. So investigations, we'd like to do some blood tests if we can. Some of our patients have really difficult venous access, so it might take some time for the clinicians to be able to do these blood tests. So we'd like to do a venous blood gas, full blood count, so we can see what the hemoglobin's doing, whether they've got loads of reticulocytes or reticulocytopenic. We'd like to see what their renal, liver and bone profile's doing, magnesium's doing, lactate, dehydrogenase, so the LDH, what that's doing. As we know, that's a sign of hemolysis. CRP, so C-reactive protein, see if there's an inflammatory process going on, or they might be bringing an infection. It's not the most ideal because we know the CRP tends to lag 24 hours. So the reading you're getting might not be what you're seeing in front of you. So always have that in mind. If they haven't had one recently, or if they've had a transfusion recently, we need to do another cross match so that if we decide these patients need blood, that we have a valid one ready to go. We'd like to know what their hemoglobinopathy screen's doing, so the sickle percentage. Unfortunately, these do take time, and usually they're couriered out of the labs, the main labs, and go to a special hematology lab. In London, it's usually the Halo, which is part of the Crick Institute. And we'll also like to look at what a reticulocyte's doing. Okay, so as required, depending on what the clinical picture suggests, if they've got temperature or recurring infection, we should be doing blood cultures. We should do a urine dip and MSU to see if there's a UTI going on that's triggered this. We should be doing COPAN and COVID swabs to check if there's a respiratory virus happening. If we have concerns about acute chest syndrome, it's best practice to do an arterial blood gas. And I mean, I've never had one done, but having seen 24 hours in A&E, seeing it done in practice, we know that's painful, and it's like a literal stab of a big needle into the wrist usually, or the femoral artery to get that. So if patients agree to it, I salute them. We need to do an ECG to check if there's any chest pains or if it's any sort of cardiac nature for the cause of pain. If we think they might be heading for acute chest syndrome, or if they've presented with a cough, then we need to rule out that there's no other chest infection that could be brewing and developing into a chest syndrome. So we could do a chest x-ray, we could do an abdominal x-ray. This is for patients who we might think be having splenic sequestration or a girdle syndrome. So it's always handy to know that. For splenic sequestration, that's usually for the children. It's quite common in my cohort, but it can happen in adults as well. One thing that's really important to do is a G6PD screen if it's not already been done. If you haven't got on your file, if it's a patient from out of area, then it's always handy to know if they're G6PD deficient. The result of this totally depends if they've had a blood transfusion recently, because if they have, then we can't necessarily get an accurate result for G6PD. So I typed in X-ray into Google and this picture came up, and I'm pretty sure that's an operating theatre, but hey ho. So critical warning signs, guys. If they come into A&E, they've presented in majors or in resus. What are the major things that we need to? What are the major things that we see that might worry us?
Low saturations.
Yeah. Give you guys the answers. So we escalate immediately to haematology and consider for urgent red cell exchange. So if we think they might have acute chest syndrome, so like Olivia says, if their saturations are lower than 94% on air or less than 4% from baseline, or more than 4% from baseline, sorry. Neurological signs, whether they've gone to GCS, whether they've got any signs of meningism, whether they've got a focal neurology, because unfortunately, as we know, stroke is quite common in patients with sickle cell disease. New asymmetrical weakness, severe headaches, symptomatic anemia, or hemoglobin that's 20 grams below the baseline. Oh, Karen, I just see the comment, meningism, so any signs of like meningitis. So if we separate out the words, ism is like inflammation, meninges is the lining around like the brain and spinal cord, so meningitis. Abdo complications, so we need to think if there's any abdominal distension, whether there's some absent bowel sounds, whether there's any dilated loops on abdominal x-ray, whether there's a large liver or spleen, whether they have signs of sepsis or they have a fever above 38 degrees C. And that's quite important as well, because if we think about how quickly and susceptible our patients are to bacterial infections due to the asplenism, and they're on hydroxycarbamide, we might unknowingly be making them a little bit neutropenic through the bone marrow suppression due to their disease-modifying therapy. So say they might have been on a stable dose of hydroxycarbamide for ages and the counts have been fine, but if their weight changed and we didn't know about it, say they've lost a lot of weight, we might be overdosing them or causing bone marrow toxicity, which is one of the side effects of hydroxycarbamide. So if they have a temperature and we find out they're neutropenic, we need to treat it as if it is a neutropenic sepsis. And also cardiovascular instability. So very briefly, just want to talk about what the specific complications in sickle cell disease are. So sepsis, as I've just said, asplenism happens due to sickling around the spleen. And the spleen is one of those magical organs that not anyone knows fully what they do. But we know that the spleen helps fight infection and helps clear out the blood. Acute chest syndrome or an acute chest crisis, this has quite a high mortality rate. It comes on quickly, patients deteriorate quickly, and if it's not treated early enough or treated aggressively enough, then we might have poorer outcomes for our patients. Stroke as well, as I said before, it's quite common, unfortunately. We monitor this in childhood. and aim to modify treatment if needed if we're showing that they've got a high chance of having a stroke. Quite a few of our patients have TIAs as well, or silent infarcts, which we don't know is happening until we notice their development slightly off. So severe acute anemia, that might be caused by an aplastic crisis. So the bone marrow has decided, like, you know what, I've had enough, I'm not going to create enough red blood cells at the moment. Usually this is caused by parvovirus, again, usually common in childhood. So if we have a low hemoglobin and we have low reticulocytes or no reticulocytes, that's just of parvo, and that's usually the main cause. So the treatment for that is blood transfusion and helping them ride it out. Hyperemolysis as well, as Karen says, we need to be mindful of the blood transfusion history. Have they had blood recently and they're just hemolyzing it? Transfusion reaction, so DHTR, so delayed hemolytic transfusion reaction. Priapism as well is deemed as a medical emergency. For those of you who don't know, priapism is a prolonged erection for more than 2 hours. And generally speaking, if they, before then, we would have contact with the patient. Usually, if they're not too nervous or embarrassed to talk about it, then they'll highlight to us that this is what's happening, and then we get them in. So UCLH, for example, is a massive urology center as well. So we get referrals from all hospitals generally, because we have the team here equipped to deal with it if it's not going away by itself. Usually for priapism, we have to aspirate out the blood because it's pretty much sickling happening in the penis, which is trapping all the blood there. We can aspirate it. We might have to put a shunt in or start medication, but usually if you've had it once, it keeps coming back, and we might need to do a surgery to install a prosthesis. Osteomyelitis, so bone infection. I don't know if you guys have ever looked after someone with osteomyelitis, but the treatment for this is a long course of antibiotics. Generally, it's about 6 to 8 weeks worth of IV antibiotics. So until you can sort out home care for people to go in and give IV antibiotics, these patients are in hospital. And sequestration. So as I said before, splenic sequestration is when the blood is getting trapped and pooling in the spleen, which causes the spleen to get massive and causes a rapid loss in hemoglobin and an abdominal crisis. So this lovely picture, for those of you who've been on my previous talks, I've used this before. As you can see in this picture, this is one of my kiddos who's been in medical journal. She's consented for her pictures to be used. If you're looking at that picture head on the left is her liver. And you can see just on the sides there, the ribs. So generally speaking, you can't feel the spleen below the ribs unless it's a little bit swollen. But as you can see, if you're looking at it on the right-hand side, that massive thing is her spleen. And that's way below the rib margin, subcostal rib margin. So for her age, she was about 6 when she had this. For her age, the spleen should only be about 8 centimeters big. Hers actually measured up about 16 centimeters. And she was quite unwell. And she's had a splenectomy afterwards and is now doing a lot better and living her best life. So other management, so we need to give oxygen to maintain sats above 94%, but as we know, we need to ensure that we do vital signs in air. Fluids, majority of patients will need IV fluids, so usually we give a litre of crystalloid over an hour. Caution is required of patients due to heart failure, whether this is due to iron overloading or other causes. Antibiotics, we should have a low threshold to start antibiotics because of the amount of bacteria and additional bacteria and organisms that our patients are susceptible to. We need to send a septic screen cultures prior to commencement. Blood products, our patients are known to run low hemoglobins generally, so normal thresholds do not apply. So for example, if we have someone with leukemia, before I did this, I used to do some cancer nursing. So when the hemoglobin hits 70, you'll be like, right, I'm ordering a unit of blood. You just don't think about it, you do it. And then the doctor prescribes and you give it. However, we have patients who are sitting in the 50s and 60s and we wouldn't necessarily give them a blood transfusion. But before blood is given, it should be discussed with the red cell team prior to prescribing it. And we need to encourage the use of insensitive spirometry. It hurts. I don't know if you guys have ever tried it, but the whole idea of it is the patients breathe in and out, deep breaths, in order to move that blue bit up. And that helps open up the alveoli to prevent any pneumonia or chest infection setting in and triggering acute chest syndrome. So fluids, as we know, fluids is treatment is most likely to influence the resolution of the vaso-occlusive crises. Patients become dehydrated because they can't concentrate their urine, which in turn causes increased blood viscosity, which exacerbates sickling. We should try oral routes if the patient is unwell, IV fluids may be needed, or if they have difficult IV access, then we might have to persevere with orals. Patients need a total bowel rates of 70 to 90 mils per kilogram per 24 hours. And we need to give 1 litre of, generally we give 1 litre of sodium chloride, 0.9% over 3 hours. And thereafter, alternate infusions of 0.9%, then with glucose and potassium in the bag. So oxygen, research shows there's no proven benefit unless there is hypoxia, although I've recognized in my patients that it helps with pain. We need to monitor the oxygen in air. If saturation is on 94% on air or below, we need to start management for acute chest syndrome to chest x-rays and start thinking about it seriously. As we know, opioids can cause respiratory suppression, so their oxygen saturation might be lower than baseline, so we need to be mindful of that. And some of our patients might develop chronic sickling lung disease, so the oxygen saturations may be lower. So I have some patients who are saturating like 90, 91%, and that's normal for them. So that needs to be clearly documented in all the plans. So prescriptions, they should have simple analgesics prescribed and analgesia as per the PKI and needle. VTE prophylaxis, so low molecular weight heparin or fragmin, dalteparin, whichever your trust stocks. Antiemetics, but not IV cyclosine. Laxatives, generally we like doing dual therapies, so we do a bulk forming agent and a motility agent. Antipyretics, so antihistamines like chlorphenamine. Naloxone for opioid reversal, opioid toxicity reversal. Folic acid, as we know, that's irregular, and prophylactic penicillin. Unless they're on any other antibiotics, which covers the penicillin as well. So I said for antimicrobials, antibiotics, low threshold for starting. There's no current evidence or basis for doubling prophylactic antibiotics if unwell. However, some of our patients take it upon themselves to do that themselves. Common infections, pneumococcal infections causing septicemia, meningitis, peritonitis, pneumonia, osteomyelitis, salmonella, osteomyelitis, haemophilus influenzae, parvovirus, staphylococcal osteomyelitis, mycoplasma pneumonia, and E. coli. So I just wanted to give you a very brief overview of what are antimicrobial guidelines. Yours will be on your own intranet. So for things like possible meningism or septicemia, first line is ceftriaxone plus metronidazole. And if it's Yersinia, we usually add ciprofloxacin. But if they're allergic to penicillin, we'll give them meropenem. And we might add in dexamethasone. However, we usually discuss with some microbiology anyway. And the course is usually 7 days. For respiratory stuff, we use coamoxiclav orally plus clarithromycin. Doxycycline as well can be added if they're penicillin allergic. For pneumonia or acute chest syndrome, cefuroxime plus clarithromycin. And we might, when we switch to oral therapy, we'll do coamoxiclav and clarithromycin. For systematic osteomyelitis, usually it's ceftriaxone, quite a big dose, twice daily. And we also might add in sodium fusidate. And if they're going home, then we tend to give them ciprofloxacin and flucloxacillin. But usually it's a minimum of 6 weeks. So all patients sick enough to require a red cell exchange should be escalated to the outreach team. We have a service called PERTs at UCLH, who are like outreach nurses who come and assess our patients and will escalate to the registrar or arrange a bed in ITU if needed. The usual referral process, someone should get referred to them, so a high news score. Any patient has a history of deteriorating quickly, even if they're currently well. Any signs of deterioration. If the PaO2 is less than 8.5 PA. So overnight and stuff, people are a bit worried about calling consultants if they get unwell. It's a standard thing. So this is where the registrar should be escalating it. Consultants should have a daily update of all patients anyway. Any patient who may need an unplanned red cell exchange. Anyone fulfilling the criteria for a PERT or outreach referral, the consultant will want to be woken up if it's overnight. Or if the registrar is a bit unsure and doesn't know what to do next. Then finally, if they're still in A&E, talking about admit or discharge. So patients who attend ED should only be discharged home if pain is manageable with home analgesia. I say it's quite rare for patients who attend ED to be able to be sent home because usually our service users are only coming in as a last resort. If they can manage at home, they will try their best to manage at home, but if they can't and need other things like a PCA or subcuts, that's the reason why they come in. Prior to discharge, the patient must remain in the department for 2 hours post-administration of any kind of opioids. A&E can give a small supply, 2 to 3 days worth of analgesia, if medically needed, but it should be discussed with the Red Cell team. And if anyone is discharged from ED, the Red Cell CNS team should be informed. So whether it's just a quick email, so we can follow that patient up. Usually we book an appointment for our patients to be followed up in Red Cell clinic. However, if that's going to be like, say they come in, say clinics on Tuesday, they come in on a Wednesday, the CNS team will follow up to check in that they're okay and still managing. If admitted, then the patient should be admitted to an appropriate ward, so usually like a hematology-based bed, or if a red cell exchange is needed and your hospital can't provide that service or can't do it out of hours or just don't have capacity to do it, then a bed needs to be identified elsewhere that could provide this service. And that's usually doctor's decision to transfer the patient in. If it can, we'll do it during daylight hours, but if it really can't wait, then we'll transfer out of hours. And that is it, guys. I don't know, my voice is a bit croaky now. Does anyone have any last questions they want to ask or go over anything?
No, I think that was brilliant. Thank you, Chris.
That's all right. Thank you. Thank you. So as we said, it's all been recorded. It'll be uploaded to our website.